Welcome, everybody. I think we are going to start. Okay, welcome, everyone. It's really my pleasure to welcome you to the Stanley and Gershoff lecture. This is the inaugural lecture of the Friedman School Speaker Series. It's a particularly poignant event for me because I actually was a graduate student when Stan was at the department that our speaker, Dr. JoAnn Manson, hails from. And so I knew him prior to coming here, but when John Mayer became the president of Tufts University, he actually appointed Stanley N. Gershoff as the director of what was then referred to as the Nutrition Institute. Within a few years, it became the School of Nutrition, then eventually the School of Nutrition Science and Policy, and ultimately the Friedman School of Nutrition Science and Policy. Stan had really very broad vision for what he thought nutrition at Tufts could be. And I think in concert with the Jean Mayer USDA Human Nutrition Research Center on Aging, we've really achieved that, and we may have even sort of exceeded what his vision was. I actually spent 9 years at Boston University School of Medicine, but ended up back at Tufts at the HNRCA. But about 20 years afterwards, I was named the inaugural professor for the Stanley N. Gershoff Chair in Nutrition Science and Policy. And I can assure you that really carries a lot of cachet in the nutrition community. So I'm really delighted to be involved with remembering and honoring Stan in terms of what he has done for nutrition at Tufts. So it gives me great pleasure to introduce our speaker, Dr. JoAnn Manson. Dr. Manson is a professor of medicine and the Michael and Lee Bell Professor of Women's Health at Harvard Medical School. She's the professor in the Department of Epidemiology at the Harvard T.H. Chan School of Public Health. She's chief of the Division of Medicine at Brigham and Women's Hospital, and she is a renowned physician, epidemiologist, endocrinologist, and is currently or has previously been a principal investigator or a co-investigator on landmark studies in the field of nutrition. So studies like the Boston Clinical Center for the Women's Health Initiative, the cardiovascular component of the Nurses' Health Study, VITAL, the vitamin, and omega-3 fatty acid trial, Cosmo, the cocoa supplement and multivitamin outcome study, and VIVID, the vitamin D and COVID trial. Dr. Manson has received numerous prestigious awards in the field, and I think one of the things that I can highlight is sort of her trifecta with the Heart Association, where she has independently received 3 of the highest awards: the Population Research Prize, the Distinguished Scientist Award, and the Research Achievement Award. She also was elected to the National Academy of Medicine. Dr. Manson, she's published over 1,600 peer-reviewed articles. She has authored or edited several books and textbooks. She was recently the editor-in-chief of the Journal of Contemporary Clinical Trials, past president of the North American Menopause Society, and notably, she's one of the physicians that's featured in the National Library of Medicine's exhibit on history of American women physicians. So I can say unequivocally that Dr. Manson is one of the most well-regarded and cited researchers in the world, and the title of her presentation is Novel Insights into Precision Nutrition for VITAL and Cosmos Trials. And please join me in welcoming Dr. Manson.
Well, thank you so much, Alice, for that very kind and embarrassing introduction. Anyway, it's wonderful to be here. And I'm also very honored to be giving this memorial lecture in the name of such an amazing pioneer in nutrition. As Alice mentioned, I'm going to be talking about some of our findings from VITAL and Cosmos. So just as a really quick overview of the talk, what I'll be discussing, I want to review key findings from our randomized trials of vitamin D and the marine omega-3s, flavanols, cocoflavanols, and multivitamins. And I'm going to be focusing on who benefits the most from these interventions, sort of precision nutrition approach, because I think it's quite clear that it's not a simple one-size-fits-all answer with these nutritional intervention studies. And I want to discuss the strengths, limitations, challenges of randomized trial research, and maybe we can get into more of those issues during the Q&A. And also, we'll review some of the implications of the findings from these trials for clinical practice and public health, and some of the next steps for replicating the findings. So I want to say really early that, as you know, research, epidemiologic research is really a team effort. And there are so many people to thank. I would take easily the next hour just thanking people, but I do want to just highlight that we really have an enormous debt of gratitude to the volunteers around the country and often the world who participate in these research studies. And as you'll hear, you know, we have tens of thousands of participants in these randomized trials. So I really do want to underscore how grateful we are to the volunteers and the participants in these trials. Also to thank all the investigator staff and our data safety monitoring board. And I want to thank Alice, who has been a member of our DSMB for so many years. I mean, easily going on 12, 13 years with VITAL and also on Cosmos. So we're very grateful to so many people. And in terms of co-authors, I want to just highlight my co-PI, Julie Buring, and everyone else on the slide, but I won't be able to take the time to go through them individually. Now, I also want to thank, again, the participants in the study and everyone else listed here for Cosmos, because we'll move pretty quickly from VITAL to Cosmos, and want to acknowledge my co-PI, Dr. Howard Sesso. And we've worked closely with the Fred Hutchinson Cancer Research Center, Cancer Center now, they changed the name, in Seattle, and we have many, many colleagues from the Fred Hutch. As disclosures, VITAL is an NIH-funded trial. It involves several institutes as listed here for the parent trial and several ancillary studies. I'll discuss several of them that have received NIH support. We do have donation of study pills from Pharmavite and Pronova Biopharma of Norway for VITAL, and Cosmos is an investigator-initiated trial of cocoflavanols multivitamins, supported primarily by Mars Edge with ancillary studies funded by NIH. The study pills were donated by Mars and Pfizer, which is now the consumer healthcare component that donated the Centrum Silver, is now part of GSK. It's called Haleon, a company, and Mars Edge donated the cocoflavanols. Now, Alice did ask me to talk about some of the challenges. Don't have a lot of time to go into this right now, but I do want to highlight, before we get into a lot of details, some of the challenges of doing randomized trials, some of the strengths and weaknesses, and be happy to come back to many of these issues during the Q&A. I think all of you know that first, no study in isolation can give a definitive answer. We're so dependent on all the different forms of research, from basic to clinical to epidemiologic, randomized trials. Some of the strengths of the randomized trials, once hypotheses are generated by epidemiologic studies and basic research, is that the randomization does help to control the major sources of confounding in and the major sources of confounding and other biases. So not only confounding, but also selection factors, like specifically with dietary supplements. Who takes dietary supplements? It's not a random subset of the population. There are a lot of factors, maybe health consciousness factors that come into play, maybe certain symptoms or indications that may lead to use of supplements. So in a randomized trial, everything else gets balanced out, except the intervention that you're giving. If it's a large enough trial, like many of these trials will go through, you have really good, when you look at your table 1, baseline characteristics, they're amazingly similar between the active and the placebo group. And then you have the placebo control. So the investigators, as well as the participants, are blinded. This is really important. Also, you have better control of the exposure than in observational studies, because as you know, there are often measurement error issues that you contend with in epi research. Here you can determine, like for vitamin D, we're going to test 2,000 IUs a day, and the capsule, the soft gel, has 2,000 IUs a day. You know exactly the difference in vitamin D intake between the active intervention group and the placebo group. With the omega-3s, you're going to give 1 gram a day in the trial, so you know what the exposure is. But there are many limitations. And over the years, I have come to recognize more and more of the limitations of randomized trials. First, compliance is not a given. You know, these are long-term trials. You often have to go on 5 to 10 years. And it can lead to decreased compliance over time, maybe suboptimal. Usually, it's a tough decision what dose to test. We made our decisions based on the best balance of safety and efficacy. However, sometimes as more research comes out, even after the trial gets started, you may regret you didn't use a higher dose, you didn't use a different formulation. So these issues arise in randomized trials, and very often it's challenging to go back and change a dose, change an intervention. There are latency periods, excuse me, there are latency periods that you have to contend with. So in observational studies, you can maybe follow for 10, 15, 20 years, and that's very feasible. You can't do that in intervention trials. You know, usually you're dealing with a shorter follow-up, and so latency, especially for cancer, can be an issue. And it's expensive. The recruitment is expensive. The recruitment is challenging. These resources that are required can be very costly. Now, something that I have learned from many years in this field is, as an obscure historical figure once said, that things should be as simple as possible, but not any simpler. You would love to have a one-size-fits-all answer from a trial and from research. You would love to be able to say, okay, if you give 2,000 IUs supplementation of vitamin D, everyone's going to benefit. Or if you give 1 gram a day of omega-3. But it really doesn't work out that way. Very often, subsets of the study population do not benefit for a number of reasons, and others seem to benefit a lot. And it leads to certain, complexities, like are these chance subgroup findings, or are they really meaningful differences related to baseline characteristics of the participants? And we'll get into that issue a little more. So let's talk about the design of the VITAL trial, which I'll start with. This is a very large-scale randomized trial, nearly 26,000 US men and women nationwide. And it's a primary prevention usual risk population. Most of the large-scale randomized trials have been in high-risk populations selected for certain risk factors. This is generally unselected, looking at usual risk people, men who are 50 years and older, women 55 and older at the start of the study. It's a 2x2 factorial design, meaning that we are able to look at the independent as well as the joint effect of each intervention with 4 study groups. So first there's a randomization to vitamin D, D3, 2,000 IUs a day versus placebo, and then further randomization to EPA DHA, this is 1 gram a day in a ratio of 1.2 to 1 versus a placebo. Mean treatment period of VITAL was 5.3 years. We oversampled Black African-American participants because we really wanted to have the ability to look at whether either of these interventions would be of benefit in that group. Now, we were particularly interested in the question of vitamin D, whether our Black participants would benefit more. So we had a goal of enrolling at least 5,100 participants. So we also had blood collections in the vast majority at baseline and follow-up bloods in close to 6,000. Now, this slide shows kind of the main results of VITAL related to CVD, and the top half shows our pre-specified, our primary outcome, which was major CVD events, other pre-specified secondary outcomes, and then other outcomes that were related to the coronary heart disease outcome in particular. So the primary outcome, we had a small but not statistically significant reduction in major CVD events as defined by non-fatal, by total myocardial infarction, fatal and non-fatal, total stroke, and cardiovascular death. That is the definition. And so that did not quite make statistical significance, but we had pre-specified total MI or non-fatal, fatal MI as a secondary outcome of interest, and it was 28% reduced. We did not see a reduction in stroke, and we're going to come back to the stroke issue. The other outcomes were related in some way to a combination of MI and stroke, and so they were obviously kind of diluted out by the absence of a benefit for stroke. You know, when you have totally null results for stroke, any composite outcome that's built on MI and stroke is going to be attenuated compared to MI. Now, we had other evidence to support a coronary benefit. For percutaneous coronary intervention, we had 0.78, which was significant. CABG was not. Fatal MI, the numbers were small, but it was significantly reduced. CHD death, borderline reduced, and composite CHD, which was MI, coronary revascularization, CABG, or PCI, and CHD death, was significant at 0.83. Now, looking, drilling down a little more deeply into the MI finding, we saw that there were certain groups that really seemed to benefit. And some of these subgroups really had tremendous biological plausibility to the findings. So one was baseline nutrient status, with fish consumption being the main contributor to omega-3 fatty acids. Baseline, we just cut it straight at the average, and this was pre-specified to look at nutrient intake as an effect modifier. We cut it at the median, which was 1.5 servings of fish per week. And we saw that those who were below the median had a 40% lower risk of MI, and those at the median or above had very minimal risk reduction. This was a significant interaction. Where we saw a really strong interaction that was not really anticipated was by race, ethnicity. We did see that our African American participants really benefited from the marine omega-3s in terms of MI and had a 77% lower risk. Overall, the p-value for interaction by race ethnicity was quite significant, and this was a very substantial reduction in African Americans, and we want to replicate. We want to see if this is a real finding. We also saw that the more risk factors the participants had, the greater the risk reduction. We didn't see any interactions by age, sex, statin use, aspirin use, or baseline triglyceride levels. Now, just briefly going through meta-analyses, how did the VITAL results compare to other randomized trials of omega-3s? Well, first, VITAL is the only primary prevention usual risk population. Every other randomized trial, and there are 13 on the slide, 13 randomized trials, there are actually more meta-analyses of the omega-3s than there are individual randomized trials. It's really quite remarkable. But they generally show coronary, signals for coronary benefit, but no stroke benefit. Let me just go through this a little. So overall, you can see that there's a little going on to the left of the vertical. There was a mean of 12% reduction of MI in all of the trials. If you exclude the REDUCE-IT trial, which tested 4 grams of a highly purified EPA, icosapent ethyl, we'll come back to that trial, there was an 8% reduction in MI in all the other trials. This was a significant reduction, but there was a 30% reduction of MI in REDUCE-IT. So why is REDUCE-IT such an outlier? Is so much stronger reduction in MI than the other trials in aggregate. Actually, not different from VITAL, which was 28%, but very different from the overall meta-analyses, the overall trials in this meta-analysis. Now, what about stroke? Stroke results have been very consistent for every randomized trial except REDUCE-IT, that there has been no benefit. Very neutral. You can see everything. Have I lost this? No. Everything is right around that vertical line. Overall, it's a little above 1. If you look at all of them together, there's just nothing going on. But REDUCE-IT had a 27% reduction in stroke. Again, a real outlier. Now, this slide shows 2 separate trials published in the last 5-6 years that showed that tested 4 grams a day of a form of marine omega-3s and had completely disparate results. So it doesn't seem to be really a dose issue. So REDUCE-IT, shown here on the left, tested 4 grams a day of EPA only, icosapent ethyl, and had a statistically significant reduction in major CVD events, the MI, stroke, CVD mortality. The STRENGTH trial, which tested a formulation of carboxylic acid, again, 4 grams a day, both of these interventions led to a 20% decline in triglyceride levels, had no reduction, actually had results that were less significant, less of a reduction in the primary endpoint than VITAL, which was 0.92. This was very, very null. So why would this be? These 2 study populations were very similar. They were high risk. They had to have at least some increase in the triglyceride levels. They had to be on statins, have established CVD or diabetes with another CVD risk factor. One question that's come up is whether the placebo used in REDUCE-IT could have influenced the findings, because this trial has been criticized for the use of a mineral oil placebo. Now, why would that be an issue? Well, in Circulation a couple of years ago, a colleague of ours, Paul Ricker, published some findings on the effects on biomarkers of the icosapent ethyl and of the mineral oil placebo. And what he published was that, and the mineral oil is shown in orange, that there were increases in LDL-C, in CRP, IL-6, some of the inflammatory markers. Many of these markers were increased during follow-up in the mineral oil group. And in the active icosapent ethyl group, there was a reduction in CRP and triglyceride, but very little change in other biomarkers. The question came up because you're comparing the results in the active intervention group to the placebo mineral oil group. Could it be that adverse effects of the mineral oil were spuriously producing this very significant finding? Also, there was some concern that the mineral oil placebo could be interfering with the absorption of statins in the placebo group. Now, this would not be occurring in the EPA group because there's nothing interfering there with the statins, but the placebo group is getting something that may be minimizing absorption or reducing the absorption of statins. And everyone was on statins in the study population. So these issues have been raised as concerns about the trial results REDUCE-IT, suggesting that a replication trial using an inert placebo would be a great benefit. Now, I want to just mention something on the subject of metabolomics, because we think that metabolomics may be an approach that could really aid precision nutrition in terms of the omega-3s. And we looked in detail at the effects of the omega-3s on changing metabolites that were linked to the downstream fatty acids and bioactive lipids, oxylipins. And what we found was that there were very major effects. There were major effects with the N3 treatment showing significant shifts in 354 of the downstream fatty acids and oxylipins. And 37 of the 354 oxylipins were actually predictive of CVD, either increasing or decreasing CVD. And what was found was that for the results kind of differed for major CVD, CHT, and MI. We'll just talk about MI first. For all of the oxylipins that predicted lower risk of MI were decreased. All of them were decreased by the omega-3s. All of these, there were 11 of them, 11 of those that were affected, that were predictive of MI, all 11 were reduced by the omega-3s. For CHD, total CHD and CVD, there were somewhat mixed findings, that some of them were, that were predictive of major CVD. The omega-3s increased, some of them decreased others. It wasn't a straightforward, every single one that was predictive of CVD would be, modified in the correct, direction by the omega-3s. It was more a mixed picture. It was only MI, suggesting that the change in the metabolites were very consistent with an effect of fatty acid, the marine omega-3 fatty acid supplementation, in favorably altering metabolites associated with lower risk of MI, but more of a mixed picture for other outcomes. So as next steps, we really do think that it's going to be very important to do a new trial of high-dose EPA. The results of Reduce It are just too promising to leave them on the table and not do anything more. But concerns have been raised, so I don't think we can know for sure that everyone in that high-risk group should be taking high-dose EPA. And also there's some concern about atrial fibrillation with high-dose EPA. So, we believe that, that the Reduce It trial, it was very promising in terms of CHD, stroke, CVD death, but the mineral oil placebo are concerns about that, and that may have contributed to some of these findings, and therefore a new trial using an inert placebo is needed. Also, importantly, Reduce It was not powered to look at high-risk primary prevention. It was really well powered only for secondary prevention among those with prior CVD. And so for secondary prevention, there was a very clear risk reduction of 0.73. But for high-risk primary, it was much smaller numbers, and the hazard ratio was 0.88. So I think we need another randomized trial that really focuses and has adequate statistical power for high-risk primary prevention, and to look at whether high-dose EPA can actually reduce risk of CVD events among those without prevalent CVD, but with several risk factors. There's another issue related to health disparities that is really requiring further research. These very strong benefits in vital, among the African Americans, which may be related to gene variants involved with fatty acid metabolism, call for some replication here, because not only in vital was there this signal for greater benefit of the omega-3s in the African Americans, but also in Reduce It. It was mostly an international trial, and they didn't have African American participants, and they had a small number of Black participants. They had mostly it was mostly a white population, non-Hispanic white, but when they looked within the group that was other than non-Hispanic white, they did see a greater benefit as well of 0.55. And by the way, the results that we're seeing in African Americans do not relate to lower fish consumption. It's not due to that, because in vital, the fish consumption among the Black participants was very similar to the other groups. And also, it's just not, that's not a plausible explanation for that much of a difference, because there was a greater difference than even seen with fish, according to fish consumption. As you know, that the U.S. Preventive Services Task Force is no longer recommending aspirin, low-dose aspirin for high-risk primary prevention after the age of 60. So there's kind of a vacuum in terms of treatments for high-risk primary prevention, that the high-dose EPA actually could potentially fill a role there if found to be a benefit in a replication trial. It might be a really effective treatment for high-risk primary prevention, as well as an add-on to this enormous armamentarium for secondary prevention. But funding is needed for such a trial. And I'm going to shift gears to vitamin D. You all know very well that we have both endogenous, exogenous sources of vitamin D. We synthesize it in the skin. We also get it from the diet. We have a fortified food supply, especially fortified dairy products, other products that are fortified in the US. And salmon has a lot, and there's some other food sources that are not fortified, but just naturally have more vitamin D, sun-dried mushrooms, for example. Now, I think the vitamin D story is one of the best examples of the enormous potential for confounding in epidemiologic or observational studies. And here are really just a few of the sources, because almost every single week you're going to hear about low vitamin D blood level, low serum 25-hydroxy-D is linked to an increased risk of heart disease, cancer, dementia, diabetes. There are so many potential sources of confounding. First, the low 25-hydroxy-D level may be more of a marker than an actual causal agent in terms of these many chronic disease outcomes. So if you have poor nutritional intake, just low intake of fruits and vegetables and dairy products and whole grains, and et cetera, you are probably also going to have low intake of the major sources of vitamin D. So poor nutrition, which we know is a big risk factor for chronic disease. Obesity, we know that vitamin D is a fat-soluble vitamin that is sequestered in the adipose tissue and may in fact be biologically available in the adipose tissue and can freely go back and forth. But blood levels will be much lower. And so if you look at blood levels of vitamin D, you're going to see many of the associations that are seen with obesity, obesity being related to higher risk of these chronic diseases. Also, people who have lower physical activity levels, just in general, are likely to spend less time outdoors, being active, walking, running, racket sports, all of that, and therefore they will get less sun exposure, UVB exposure, and will have a lower 25D. So is the lower 25D just a marker for all these other factors and not necessarily causally related? And we know correlation doesn't prove causation. There are even other factors that may be at play, such as their chronic diseases can deplete and lower the vitamin D binding protein, actually lower the vitamin D blood level just from having chronic diseases. So that's obviously going to further obscure associations. I'm sure everyone in this room knows the Institute of Medicine guidelines for vitamin D, now called National Academy of Medicine, released in 2011, but they really have not changed since then. And I'll just briefly mention a few things. For adults, actually ages 90 to 70, men and women, the recommended dietary allowance, 600 IUs a day, we'll come back to what that means. For age above 70, men and women, 800 IUs a day, and a tolerable upper intake level of 4,000 IUs. Now, what does the RDA actually mean? It's defined as the intake that covers the needs of at least 97.5% of the generally healthy population in the absence of sun exposure in the case of vitamin D. So this is basically what you would need if you were living in Antarctica during the winter. How much vitamin D should you take with you? Usually 600 to 800 IUs a day should meet your needs for bone health. And this was the main outcome that was of interest to the IOM, because it was the only outcome that had been well shown to be related. Now, the tolerable upper intake level is a level above which there is risk of adverse events. So this suggests as long as you stay anywhere in this range, 600 to 4,000 or 800 to 4,000, it's probably safe. You don't have to stay as low as 600 to 800. You could get 2,000, even 3,000, up to 4,000. Without actually incurring a risk of adverse events. Now, what about the recommended 25-hydroxy-D level? You probably know that many of the clinical labs are giving the message that you have to get to 40 nanograms per mil, 50 nanograms per mil, multiply by 2.5 to get to nanomoles per liter. This is much higher than the IOM thought was necessary. So they set a level of above 20 nanograms per mil or 50 nanomoles per liter as the level corresponding approximately to the RDA. And also the tolerable upper intake level was set at 50 nanograms or 125 nanomoles per liter, kind of cautioning against chronically staying above that level. So what did we find in terms of vitamin D in Cosmos for total invasive cancer? The primary endpoints, no reduction. But for cancer death, we did have a signal that was almost significantly reduced. I'm going to show you some meta-analyses that bear that out. All-cause mortality not reduced. We pre-specified that we would look at the latency by excluding the first 2 years of follow-up. And there we did see cancer death starting to emerge as significantly reduced. Now, there is a view based on basic science, laboratory animal research, that vitamin D may actually affect tumor biology in terms of how invasive tumors become and whether metastasis occurs, but may not really affect the earliest stages of carcinogenesis and affect incidence of cancer. So in a meta-analysis, 5 randomized trials that were large enough to look at cancer, we did a meta-analysis. We published a few meta-analyses on this subject. It seems to require daily vitamin D, but this is just looking at all the vitamin D trials. So the one trial that didn't show anything was a bolus dosing trial, like a monthly rather than daily dosing. And overall, taking all these trials together, there was a 13% significant P0.005 reduction in cancer mortality based on vitamin D trials, but no reduction in cancer incidence, no effect on cancer incidence. However, we did see a signal for cancer incidence when we looked at the participants who had a healthy or normal body mass index. And we had pre-specified in our grant to the NIH that we were interested in effect modification by BMI because the results might differ given the sequestering of vitamin D in fat tissue and all that. Now we did see, this is for total incidence of invasive cancer. We saw there was a little bit of an interaction, but not significant by race, ethnicity. African Americans did have 23%, but not a significant reduction. Body mass index was a really strong effect modifier with a significant 24% reduction among those with BMI less than 25, no reduction in other groups. And we did not see effect modification by baseline level of 25D, although admittedly we had few participants with very low blood levels. We did not have a modifying effect of age or sex. Now, when we looked at an endpoint, which we pre-specified in the next renewal grant, to look at advanced cancers, metastatic plus fatal, based on this view that vitamin D might affect cancer biology, we did see a significant reduction in that endpoint of advanced cancer, metastatic plus fatal cancer. Again, it was about a 13% reduction. And again, for the endpoint of cancer mortality, we had the BMI effect modification, actually a 42% lower risk of cancer mortality among those with a normal BMI below 25. Now, I want to mention that effect modification by BMI has been found for a few other endpoints as well, including diabetes. We'll soon be publishing our specific findings in Vital on diabetes, but meta-analyses have been done, and what they tend to show of other randomized trials of diabetes, of vitamin D and diabetes, is that, for example, if you look at those participants who are not in an obese BMI range, there is a reduction, but no reduction in the obese range. This was also found in the D2D trial, testing a dose as high as 4,000 IUs a day, that even with 4,000 IUs a day, there was no reduction in type 2 diabetes among those with higher BMI, a BMI above 30, but there was close to a 30% reduction in T2D among those with a BMI that was not in the obese range. So two separate meta-analyses have shown effect modification by BMI, a reduction and in risk of type 2 diabetes with vitamin D supplementation among those who were not in an obese range, and no reduction among those in an obese range. We also saw a benefit for autoimmune, a composite autoimmune disease endpoint that included rheumatoid arthritis, psoriasis, lupus, many of these outcomes in combination. We didn't have enough power to look at them individually. You know, overall, we had a significant 22% reduction with vitamin D, kind of borderline for omega-3s. But again, with vitamin D, we saw in those who had a BMI below 25, who were in that healthy BMI range, the hazard ratio was 0.62 for autoimmune diseases, and it was minimally reduced among those with higher BMI, and this was a significant interaction. Now, this slide just kind of combines all of our findings by body mass index, because we really do think that BMI is an important factor that needs to be explored further. Because if there's a way to make vitamin D effective across the board, irrespective of BMI, this would be really, really important clinically and in terms of public health. There's something about higher adiposity that is interfering with the bioactivity of vitamin D. And when we look at, this is BMI less than 25, this is the overweight group, this is the group with above 30, these are very consistently below 1.0. Many of them are significantly reduced. We talked about total invasive cancer, advanced cancer, cancer death, autoimmune disease, also depression, falls, urinary incontinence, percent body fat. We're seeing these benefits emerging among the group with BMI less than 25. Very little going on in the other BMI groups, and interaction by BMI that is either statistically significant or close to significant. This doesn't seem to be due to something as simple as just not getting the 25-hydroxy-D level high enough. Because if that were the problem, all you would have to do is adjust the dose and give more. And a trial like D2D that tested 4,000 would probably have been of benefit even in those with higher BMI. So what we, in some work by Didi Tobias and in our division, is looking at the group, the placebo group, and the assigned vitamin D group over time, comparing baseline year 2, according to the BMI group, normal, overweight, obesity 1, obesity 2. And what you can see is that generally at baseline, the 25D was a little higher among the normal weight group, but these are pretty small differences. And also over time, there was some increased, greater increased level of 25D among those with lower BMI than the other groups, but very small. It would not be enough of a difference to account for really varying hazard ratios across these BMI groups. So vitamin D, just quick summary before we move on to cosmos. Vitamin D, I think a conclusion from all of these results is that our bodies are designed to require only really small to moderate amounts of vitamin D. This may be because vitamin D is so crucial to health that we have all kinds of physiological adaptations to conserve vitamin D, to change the conversion to the active 1,25-dihydroxy-D, to save vitamin D. And we require very little supplementation unless you are not getting sun exposure and you're not getting really having a very limited diet. And there are groups. There are going to be groups like people who have malabsorption, people who already have significant bone health problems on medications, residents of nursing homes. There will be people who will benefit from vitamin D supplementation, even above the RDA but most people may not require that based on the findings. This is not only vital, this is so many randomized trials of vitamin D that the benefits seem to be very limited of higher dose supplementation. Vitamin D does show intriguing effect modification by BMI. This does warrant further study. So one thing that we would like to do, and we're trying to pursue, is looking at the bioactivity of vitamin D supplementation according to BMI group and adiposity measures using some of the measures we're interested in terms of biomarkers are metabolomic changes from vitamin D supplementation, proteomic, like the proteomic changes that relate to inflammation, gene expression profiles. Seeing if this hypothesis is true, then you would expect you're going to get much more bioactivity, changes in the metabolome, changes in the proteome, changes in gene expression among those with lower BMI than higher BMI. And so we want to look at that. Also, it may be that with higher adiposity, there's impaired metabolism and conversion to the active. So maybe giving a more metabolized form of vitamin D, such as calcidiol, possibly calcitriol, could bypass some of the limitations. And vitamin D supplementation appears promising for reducing risks of advanced fatal cancer and autoimmune diseases. So I think this needs to be pursued further, and whether there may in fact be a benefit of supplementation at these higher doses for those who are at elevated risk of these conditions. Moving on to the Cosmos trial, again, a very large trial, more than 21,000, 2x2 factorial design, cocoflavanols 500 milligrams a day. Median treatment period was shorter. It was only 3.6 years. Now, as I mentioned, Dr. Howard Sesso was a PI and led this paper I'm going to discuss, looking at the effects of the cocoflavanols on CVD. What we saw was for our primary endpoint, that was total CVD events, there was a signal, 0.90, did not quite make statistical significance. Just about everything overlapped with 1, but was on the side of benefit. But CVD mortality was significantly reduced by 27%. And the endpoint of major CVD events, which was the endpoint we used in VITAL, this was significantly reduced by 16% in Cosmos. This slide just shows graphically. So for our primary endpoint, we have some biological plausibility in that the curves were essentially superimposable up until about 2 years, and then they started to diverge with a lower risk in the active cocoa extract group. And here for CVD mortality, again, they were pretty much overlapping until a year and a half or 2 years, and then diverged. We did per protocol analyses where we censored once a participant was non-compliant with study pills. And these results were actually surprisingly supportive of the hypothesis of a benefit of the cocoflavanols in reducing CVD. So in these analyses, we did see a significant 15% reduction in our primary endpoint of CVD mortality. We also saw the combination of CVD mortality and all-cause mortality reduced. We had a 25% reduction in, wait a second. I'm sorry. It's hard to see. There's so many things here in stroke. And for CVD death, we had 39% reduction in the per protocol analyses, and for the major CVD event outcome of MI, stroke, CVD death, we had a statistically significant 24% reduction. So this was pretty, surprisingly strong in the per protocol analyses. Now, moving on to multivitamins. I want to just comment that the U.S. Preventive Services Task Force published 2 years ago on multivitamins and other dietary supplements and whether they should be taken for prevention of cancer or CVD, and concluded that they shouldn't. But if you looked closely at their meta-analysis that included all the randomized trials that had been done of multivitamins and then a lot of other dietary supplements, you could see that there was actually a significant reduction of cancer with multivitamins. This is based on Physicians Health Study 2 and included Cosmos. They asked for our data in Cosmos. And 4 randomized trials was associated with a 7% reduction. This may seem like nothing, but actually a 7% reduction in cancer in even the US population alone. It's tens of thousands of fewer cases of cancer, and globally, obviously, huge numbers of cancers delayed or prevented. They saw also a pretty promising signal for all-cause mortality. I know this isn't that exciting, but for all-cause mortality, we have accidents and many outcomes not related to chronic disease. This is a very favorable result. CVD really did not show anything. We were involved with the Physicians Health Study 2 and published these results in 2012. And what we found in PHS2 for multivitamins, it's also a Centrum formulation, over 11 years, so we were able to continue this for a very long time. We saw this 8% reduction, again, started out with not much going on, but the curves began to diverge around 3 years. And continued divergent through the follow-up period. Interestingly, we saw a greater benefit among the older men. This was all men in this trial. The men who were 70 and older had an 18% lower risk of cancer, and this may be related to poor nutritional status in older adults and perhaps poor absorption of nutrients. But the P for interaction by age was borderline. We also saw, in addition to 8% reduction in total cancer incidence, a 12% reduction in cancer mortality. In Cosmos, we did not see too much going on with cancer. It was only 3.6 years. We think it was too short, so we want to follow the participants longer term. Overall, the hazard ratio was 0.97. We saw a reduction in lung cancer, really nothing else. So we are interpreting this as so far null, but a benefit may emerge with longer follow-up. Now, I'm going to end with some discussion of cognitive function, where we have some really exciting findings on multivitamins. And we had 3 separate ancillary studies in Cosmos that looked at cognitive outcomes using different methodologies and even excluding any overlap in the 3 separate study populations. One looking at telephone-administered cognitive assessment, one a web-based online assessment, and the third more of a standardized gold standard in-person assessment. Now, what we first published on was Cosmos Mind, which was telephone-administered, very detailed testing by phone. We did not see much going on in that study with the cocoflavanols, but the daily multivitamins showed cognitive decline by 60% over the 3 years, was a significant p-value. This translated, based on looking at differences in cognitive function by age, to about 1.8 years of slowing compared to placebo. Also, the large-scale web-based study, Cosmos Web, this was up to 3 years of follow-up. We pre-specified that the primary endpoint was at 1 year. We had better performance in the multivitamin group than the placebo group at 1 year. It continued over 3 years and became more strongly, significantly of benefit. And compared to the placebo group, this was estimated to be about 3 years of cognitive slowing over the trial. And this was limited to the primary endpoint for this trial, which was hippocampal age-related memory loss. And other domains were not as rigorously ascertained. Then we did a meta-analysis of the in-clinic visit assessment, as well as these others, altogether excluding all overlap. And what we saw, you can see we pre-specified looking at global cognition and episodic memory. And we saw for global cognition, it was looking at the in-clinic visit group and Cosmos Mind, almost identical results, which is pretty amazing. Completely different methodology compared to placebo, a significant benefit with a P, combining the two, a P of less than 0.001. For episodic memory, which all three ancillary studies contributed to, and all showed benefit. Actually, the greatest benefit was in the in-clinic standardized, very standardized assessment. That was, again, a P of 0.001. So overall, we had strong and consistent benefits of a daily multivitamin versus placebo on preventing memory loss, slowing cognitive aging in older adults. The way we translate this is that multivitamin effects on global cognition overall, taking all of these studies into account, were comparable to having about 2 fewer years of cognitive aging over the 3 or so years of the trial. I'm going to just mention very briefly, for cocoflavanols, we did see a signal, sorry, that those who started out with low flavanol intake did seem to have a benefit of the cocoflavanols in age-related cognitive decline. So my last slide here. Sorry, it's a lot of material. Vitamin D, marine omega-3s, cocoflavanols, they all show promising results for selected outcomes. And I think these findings now call for replication, because you can't say, you know, based on these findings alone, everyone in the world should be taking these supplements. But with replication, there could actually be public health recommendations. So the replication trials of the marine omega-3s, I think really should focus on high dose EPA at this point, based on the overall results of the trials, and a diverse study population that includes a large number of African Americans, to see if that finding can be replicated. And a replication of flavanol epicatechins to see if the CVD benefits, especially in that per protocol analysis, can be replicated. Vitamin D shows intriguing effect modification by BMI. This warrants further study. Also, I think requires a replication of the benefits for autoimmune, preventing autoimmune diseases or reducing those risks. Multivitamins show promising, unexpected. No trials really had suggested this benefit before to any large extent, and they hadn't looked at it, basically. And has replication across the 3 separate ancillary studies. Already we know prenatally it's so important for women during pregnancy and even prior to conception to be taking multivitamins. Small reductions in total cancer and PHS2, borderline reductions in all-cause mortality. The question is, are they ready for prime time public health recommendations, given the very low risk, such safety demonstrated for over 11 years in PHS2, high accessibility and affordability? Would be interested in your thoughts about this. Obviously, guidelines committees will have to weigh in on this question. And we have many opportunities for collaborations for those who may be interested. And thank you so much for your attention. My email is there. Thank you.
Okay, I know some of the students need to leave, and we apologize for that. But do we have any questions? I actually, well, people are considering it. I'll start off. Could you say something about what you went through with the omega-3 fatty acid trial as far as the supplements and stability testing? Because that's one thing that I think can be quite challenging with intervention studies.
Yeah. Well, because we had two interventions, we want to use calendar packs or blister packs. So it was really easy for the participants to remember to take the study pills each day. And it's difficult with the omega-3s that can be susceptible to oxidation and even becoming rancid over time. The quality of the study pills has to be tested with accelerated, using high temperatures, high humidity to be sure that whatever packaging is used, whether it's a pill bottle or a blister pack, calendar pack, that there's adequate protection of the study pills. So we did have to do extensive testing. The initial stability tests were not optimal. We had to change the blister pack ingredient, components, so that we had better protection of the study pills, and we were finally able to have really good long-term stability.
This is some of the under-recognized challenges of conducting these types of long-term studies. Do we have any? Yes, Dr. Kennedy.
Okay, good. JoAnn, I'm a big admirer of your studies, so thank you. This was terrific. At the height of COVID, the COVID epidemic, Anthony Fauci made a comment that supplemental vitamin D intake could be helpful. Shortly after that, I was on a scientific conference by Zoom, and there were some French researchers that expressed concern with that recommendation, and the concern centered around vitamin D being a possible endocrine disruptor. And I wondered what the evidence on this was. And secondly, so many of the studies you talked about, multivitamins, was there much variation in the nutrients in there, the amount of the nutrients, and were any of those nutrients above the upper level?
So in terms of the last question, there's not that much variability. Most of the multivitamins contain at least 20 of the essential vitamins and minerals, and it's usually at the daily intake level. But there are certain variations, like the Centrum's, it does include 1,000 IUs of vitamin D as opposed to just 600 or 800. So there are some minor differences. Also, over time, the multivitamins have changed to include lutein and varying doses. But I would say generally you want to look for a high quality. I don't want to promote any specific brand here. A high quality multivitamin that has some seal of external quality auditing, such as USP or NSF, that kind of thing. In terms of Dr. Fauci's recommendation, so we're actually almost done with our trial of vitamin D and looking at COVID severity, symptom severity, as well as long COVID. There have been very, very few randomized trials of vitamin D that actually clearly show benefit in the past. At the time that recommendation was made, I think it was more based on, some of the theoretical benefits of vitamin D in terms of having an anti-inflammatory effect, which it does have, that it might tamp down inflammation, and which was leading to some of the severity of symptoms, especially early in the pandemic. But there wasn't a lot of rigorous evidence from randomized clinical trials. And some of the randomized clinical trials of vitamin D and COVID severity, COVID incidence, have shown no benefit that have been done in the past. Now, I can't give the results of our trial, but we're expecting to publish, and we're still in data analysis stage, expecting to publish by very early 2025. I think it depends on exactly how endocrine, it can have an interaction with the estrogen receptor. they are sex steroid, you know, in some ways they're endocrine hormones, and they have, you know, affect the nuclear receptors. But I don't think to the point where we would have to worry that vitamin D would interfere with, let's say, puberty or reproductive, you know, stages. I don't think there's any evidence for that.
We have time for one more question. Do we have one? Back there, Dr. Das, all the way in the back.
Thank you for the talk and all of the elegant studies you presented. How, in your sort of understanding, are you going to be handling this very new, we had COVID, of course, but this very new surge in the use of GLP drugs in both for diabetes management as well as for weight management, of course, with the BMI confounding as well, or effect modification, pardon me, as well as a potential apparently, you know, indication for cardiovascular disease management as well that's on the market. So thank you.
Yeah, I think it will be important for all randomized trials on almost any topic to be taking into account use of these medications and be able to stratify by their use. You know, if the GLP medications end up leading to a lower prevalence of obesity, it may make vitamin D actually of greater benefit based on what I showed you with the BMI effect modification, but it isn't likely to be like the answer to this problem. You know, there's still, I think, will be a need to find a way to make vitamin D more of greater benefit and more effective, even in those who have higher BMI.
Great, thank you. So I want to close us out today. First, I want to thank Alice and acknowledge the incredible work she does and as our Gershoff professor carrying on the legacy of Stanley. And I also want to acknowledge our Gershoff scholars who are in the audience today: Kenya Palmer Emmerich, So-Young Lee, Xiaotian Shen, Ana Mofs Rodriguez, and Haihan Zhang. So thank you to all of you. And want to and between all the incredible scholarship and people working at the school under Stanley's name, I can't think of a better way to honor nutrition science and everything that he did than having JoAnn speak today. That was a clear and incredible talk. Thank you so much. And we have a plaque to acknowledge you joining us today and to honor all the work. Please stand in the middle and we'll get a photo. All the work done. Thank you so much, JoAnn. That was incredible. And thank you for at the end for saying we're open to collaboration, because we have lots of people here who are moving their way through their dissertation, their degrees, and are continuing to pursue their scholarship. So want to invite everyone now to join us for lunch in the cafe, and outside we have tables flowing out. And thank you all for coming today.